Dear friends and colleagues, thank you for the invitation to be present on this MIPS meeting. Unfortunately, I will not be able to be present, but online I will do my pre-recording of my presentation. My topic is what to do for recurrent urinary tract infection in female patients. I have no conflict of interest. So first of all, recurrent urinary tract infection is defined as at least 2 urinary tract infections within 6 months or at least 3 months urinary tract infections within 12 months. So recurrent urinary tract infection can be classified into 4 groups according to the pathophysiology and type of microorganism. Sometimes we classify it in 4 groups as unresolved bacteriuria, persistent bacterial infection, relapse or reinfection, the same bacteria. Pathophysiology of recurrent urinary tract infection is woman. Healthy female urogenital flora consists of lactobacilli as the main organism. Most are Lactobacilli crispatus, Lactobacilli jenseni, and Lactobacilli iners. All of them do low vaginal pH. During infection, usual pathogens are E. coli, followed by Staphylococcus saprophyticus, 10 to 15%. Enterococcus, Klebsiella, Enterobacter, and Proto species are less common causes. In diagnosis of recurrent urinary tract infections, dysuria without vaginal irritation or increased vaginal discharge is a highly specific symptom with more than 90% of accuracy. Patients might develop the dysuria concomitant with increased urinary frequency, urgency, hematuria, and now or worsening urinary incontinence. In diagnosis of recurrent urinary tract infection, you should consider history of lower urinary tract symptoms, hematuria, pneumaturia, fecaluria, spermicide use, and other contraceptive methods, sexual partners, sexually related urinary tract infections, bowel symptoms, previously documented urine cultures, recent use of antibiotics, back or flank pain, catheter usage, incomplete bladder emptying, vaginal infection or inflammation, menopausal status, and estrogen use and neurological disease. Here, in this table, you can see risk factors for complicated urinary infections, and the main risk factor is intercourse in the past months. Predisposing factors for recurrent urinary infections, many of them are immunosuppressions, nosocomial factors and instrumentations, urinary tract anatomic abnormality, urinary tract obstruction, and voiding dysfunction. According to the diagnosis, differential diagnosis of recurrent dysuria can be acute pyelonephritis, atrophic vaginitis, bladder cancer, cystitis, genital herpes, interstitial cystitis, irritant cystitis, overactive bladder, sexually transmitted infections, urethritis, and vaginitis. In assessment of women with the symptoms, first of all, you have to consider the symptoms, the risk factors. Does she have pain or fever? Is there any vaginal discharge? And in some cases, you should do urine culture at least. According for the treatment of initial recurrence of urinary tract infection is the same as for the other cases of uncomplicated cystitis. The antimicrobial susceptibility profile for uropathogens in a community should guide treatment decisions. So anyway, the guidelines said that 3 days of trimethoprim sulfamethoxazole is standard therapy with 3 days of trimethoprim, 1 day of fosfomycin, 5 days nitrofurantoin, and generally fluoroquinolone is not first choice, and you should consider resistance for fluoroquinolones. According to prevention for recurrent urinary tract infections, antimicrobial prophylaxis has proved effective in reducing the risk of recurrent urinary tract infections in women with 2 episodes of infection in the previous year. The duration of prophylaxis should be guided by the severity of patient symptoms and by physicians and patients' preference. Some authorities have recommended longer courses, 2 to 5 years, in patients who continue to have recurrent symptomatic infections. These are some of the guidelines for the prevention with antibiotic prophylaxis. Trimethoprim 100 milligrams once daily, trimethoprim sulfamethoxazole once daily, nitrofurantoin monohydrate 50 to 100 milligrams per day, cephalexin up to 250 milligrams once daily, and fosfomycin 3 grams every 10 days. Postcoital prophylaxis may be preferable in women with urinary tract infections temporarily related to intercourse. Antimicrobial prophylaxis has proved effective in reducing the risk of recurrent urinary tract infections in women with 2 episodes of infection in the previous year. Women with previous urinary tract infections who are able to recognize the symptoms can be treated effectively without self-started antibiotic therapy. Also, you have to consider behavioral changes which can affect the frequency of urinary tract recurrence. So managing recurrent infection should include modification of known risk factors. So several studies of postmenopausal women have demonstrated the effectiveness of using topical estrogen estrovaginal cream nightly for 2 weeks, then twice weekly for 8 months. But there is some adverse effects which are common. Also, we should mention for the postcoital infection, several studies shown benefit from transpositioning of urethral meatus. These are studies for the antibiotic prophylaxis, and for non-antibiotic prophylaxis, we'll mention some of them. Acupuncture can resolve symptoms but not urinary tract infections. Canberry products by the EAU guidelines set the level of evidence 1A, which weak recommendations. AUA guidelines set level C recommendation. Demanose by the EAU guidelines show that it gives a weak recommendation. Chinese herb, it might help resolving symptoms together with antibiotics. Vaginal estrogen, already mentioned, reduced pH. By the EAU, there is level of evidence 1B, and it is a third recommendation in postmenopausal women. Hyaluronic acid with or without chondroitin sulfate by the EAU recommendation says level of evidence 2 with weak recommendation. Methenamine hippurate, which is bacteriostatic agents, there is no recommendation from the EAU guideline. And probiotics, oral, not vaginal, but oral not, but vaginal can be done by EAU, said level of evidence 1B with weak recommendation. Also, we should mention vitamin C can decrease incidence of symptoms by 30%, and vitamin D act on immune response and might prevent urinary tract infections. Also, for the electrofulguration, women who have recurrent urinary tract infections after 1 session of electrofulguration may benefit from a 2nd or 3rd session of treatment. For the non-antibiotic prophylaxis, we should mention also some vaccines. You know well-known Urovaxone. By the EU guidelines, there is level of evidence 1A with strong recommendations. MV 140, Euromune. It's effective given oral route, but there is a high percentage of side effects. FIMH vaccine is given by intramuscular route. This vaccine is bacterial adhesin protein called FIMH. It's adjuvant with the TLR4 agonist, which activates antibody production and leads to reduced binding of E. coli to bladder cells. This new vaccine is in development stage 2, the EXPEC4V. This is vaginally suppository of heat-killed uropathogenic bacteria, which significantly reduce the risk of recurrent urinary tract infections compared to placebo in meta-analyses. These are studies regarding non-antibiotic prophylaxis, already mentioned. These are guidelines for management of recurrent complicated urinary tract infections. We should mention some of them, especially for the parental antimicrobial therapies indicated if patients are unable to tolerate oral therapy. The duration of therapy should be 7 days for patients with low urinary tract symptoms and 10 to 14 days for patients with upper urinary tract symptoms or sepsis syndrome. Patients with chronic use of urologic devices should receive the shortest possible duration of therapy to limit antimicrobial pressure leading to resistance. Whenever possible, genitourinary abnormalities should be corrected. Prophylactic antimicrobial therapy to prevent recurrent urinary tract infections is not recommended for patients with complicated urinary tract infections. Suppressive antimicrobial therapy is indicated to prevent frequent recurrent infection for selected patients with persistent genitourinary abnormalities. And for a young woman with catheter-acquired urinary tract infections, treatment of bacteriuria persisting 48 hours after catheter removal may be considered. As a conclusion, according to this mentioned data, although data from multimodality cannot guarantee to cure 100% of recurrent urinary tract infections, it seems to achieve a high success rate in several ways, and still need the long-term data of the vaccines that seems to be the new door for the treatment. Thank you very much. I wish you good Congress and all the best.